afternoon now. Thanks for your perseverance throughout the day. So I was asked to talk about checkpoints inhibitor and autoimmunity, and I must say I will try my best to do the justice to this topic in less than 20 minutes, but it's massive. And I learned a lot along the way when I was preparing this slide. And to me, I think before we talk about checkpoint inhibitors and autoimmunity, we need to understand what are the checkpoint inhibitors themselves. Immune system in humans is very carefully regulated to allow protection, but at the same time self-tolerance. And there are multiple molecular mechanisms that participate in it, in addition to the deletion of the autoreactive T cells and B cells and thymus and bone marrow during development. Autoimmune diseases occurs when these checkpoints are breached. And the checkpoints are usually regulated by these small molecules, the co-inhibitory molecules, which blunt the response of T cells to the stimulation. What they do is that they promote a state of exhaustion, leading to the ineffective responses upon recognition of self or benign foreign molecules. So the longer the exposure, there's exhaustion, there's energy, and then in a way, autoimmunity is suppressed. But what happened that tumors also utilize these mechanisms to escape the immune surveillance? So the same immune checkpoints, if they are breached, you get autoimmunity. But if they are maintained, your autoimmunity risk is smaller, but at the same time, there is a chance that the tumors will not be recognized. So now comes the checkpoint inhibitor therapy, basically exploiting the same small cell molecules, the inhibitory molecules, two ligands mostly, CTLA4 and PD-1 ligand, and the therapies basically target them so that the T cells which has stopped to recognize them as tumors are now re-stimulated and kill their own tumor cells. So in a way, it's a autotherapy. The T cells are stimulated to kill the tumor cells by these checkpoint inhibitor therapy that are given. So that's a little bit of background before we go into what happened when we give the checkpoint inhibitors and how come the autoimmunity come in. The point to highlight is that the autoimmune and the tumor recognition are kind of two divergent arms from the same pathogenesis. You work on one, you run the risk of incidentally or stimulating the other. So although immunotherapy has been around for decades in cancer, it's only in the last 1 decade that checkpoint inhibitor therapy has come on board. These mechanisms were recognized somewhere in 1980s, but it took decades before the first drug was approved in 2011. And since then, the therapies as well as their uses are really exponentially increasing. Sorry, I don't think so I can get the pointer working. But basically, more and more drugs, 2 pathways, CTLA4 pathway, PD-1 pathway, more and more drugs, and more indications. So rheumatologists, be ready. The storm is coming and the use is increasing, so you will see more and more of this. We have to know what it is and work on it. As I mentioned, what happened when we give the checkpoint inhibitors in cancer therapy, the same co-inhibitory molecule that was supposed to suppress autoimmunity is now unleashed. End result, you can get autoimmunity. That's just common sense, right? So in health, which is in the center, see, these two things are balanced. You have these small molecules that are inhibiting autoimmunity, but at the same time, they're clearing pathogens, but they still retain some activity, so malignant cells are cleared. When there is a tumor, basically this is breached. Your tumor cells are growing and growing. By giving checkpoint inhibitors, you are trying to bring it here, but it can overshoot. And the result is you get an autoimmune disease. So it is thought to be because of the enhanced T cell activity, as I mentioned. The immune-mediated adverse events from checkpoint inhibitor therapy are extremely common. They occur in up to 90% of the patients who receive checkpoint inhibitors, and they can affect a variety of organ systems. Rheumatologic IREs occur in 5 to 10%. So almost a big chunk of patients are getting this. Any organ system can be affected, but it can be endocrine, it could be ophthalmic, it can be GI. GI is the most common. Rheumatologic in about 5 to 10%. So be aware that any organ system can be affected. The other thing to keep in mind is, although they are autoimmune phenomena and they broadly mimic the diseases that we are used to treating, they are different. It is an iatrogenic autoimmunity in a way, and the phenotypes as well as the immunologic pathogenesis is different in most of the cases. Most common rheumatologic IREs are arthritis. The inflammatory arthritis can range from large joint polyarthritis, like similar to reactive, similar to RA, every kind of our well-known inflammatory arthritis can be represented, even your RSP3E. The differentiating factor is most of these patients are negative for your traditional antibodies, although ANA can be positive. So any form of arthritis can occur, generally seronegative. PMR is pretty common, but it can be very sudden, with stiffness and pain, and atypical features may be present. So in every manifestation, you will see atypical features. Sicca, very abrupt onset. And I'll elaborate. Sicca is quite different. Myositis and sicca are significantly different when they occur in this setting. Myositis can occur very early after treatment with ICIs. I will call immune checkpoint inhibitors as ICI. Myalgias often precede weakness, which is unusual in your usual myositis. Skin involvement is rare, and it can occur with concurrent myasthenia gravis. And your usual antibodies are generally negative. Scleroderma can happen, although it's a bit late, and vasculitis. Any form of vasculitis can happen. So as I just mentioned, sicca is very different phenotypically. The gender differentiation is not there. That's your usual sicca syndrome in Sjogren's, and this is your ICI. Equal gender distribution, the immunophenotype is different, histopathologies are different. Myositis, very severe, and a lot of myositis is associated with myocarditis as well. Severe disease can be very life-threatening. There's a specific T cell clone that has been identified, and there's work going on. So it's a very different disease. It is not your usual autoantibody-mediated inflammatory myositis. It is ICI-induced myositis, which can be lethal and often is associated with myocarditis. So be aware. Okay, sorry. Of course, we have now, rheumatologists initially were very worried, at least in my center. When we first heard about this, we were like, oncologists are creating it, they should treat it. But now we know we have to hold their hands. So EULAR has come up with recommendations as to what should we do. And they say the role of rheumatologists is to assist oncologists in the differential diagnosis as well as help them with the symptom management so that patient can continue treatment. The thing is, oncologic treatment can be potentially life-saving. These are symptoms, most of the time not so lethal, sometimes lethal, but often just more symptomatic. The priority becomes life-saving, which means you want to continue your cancer therapy, but your patient has inflammatory arthritis. So our job is then to control the arthritis by whatever means we have so that the oncology can continue their treatment as much as effectively as possible. And we need to be aware that there's a wide spectrum of clinical presentations and that they do not often fulfill traditional classification criteria of rheumatic diseases. So do not expect your garden variety rheumatic diseases. So how do you evaluate them? When you are faced with a patient who is undergoing the ICI therapy and is now developing some kind of symptoms, of course, your usual stuff. And a lot of it is also to exclude other things. Myositis, just be aware that you need to, although you will still do the myositis panel, you do need the enzymes, EMGs, and MRI of the affected muscles. And for vasculitis, basically a full evaluation. How do you grade? Because your treatment depends on the grading and the severity of ICI. The IRAE's immune-related adverse events are graded according to this terminology, which is by an oncology society for any adverse effect that happens during oncologic treatment. Grade 1 is just mild, asymptomatic or mild symptoms, no intervention required. Grade 2 is moderate. When you do need to do some intervention, it's affecting their ADLs. Grade 3 is medically significant or severe, not life-threatening, but may require hospitalization. Grade 4, life-threatening, and grade 5 is death. So taking inflammatory arthritis as an example, if you have grade 1, mild joint pain symptoms, you do your rheumatologic investigations, your whole panel of investigations, but then your management is guided by your grade. If it's mild, you continue your immunotherapy. You can give NSAIDs, you can give a bit of steroids, and you continue follow-up. So that in case they are going into this range where it's becoming moderate, then you do consider holding immunotherapy, because holding immunotherapy is a major decision that has to be made in a multidisciplinary decision. Holding immunotherapy means you are denying that patient their cancer treatment. So before you do that, you try other things. This one is just consider. There are situations where we treat the IRAEs with whatever immunosuppression, but continue the immunotherapy, so that can be an option as well. If they are severe, then of course you have to hold off the immunotherapy and treat them with immunosuppression. Again, it's from EULAR. They also recommend the same thing, that if the patient is experiencing severe diseases, then you can consider your conventional as well as your biologic DMARDs, including TNF or IL-6. The decision to hold or continue to cancer immunotherapy, it depends on the severity of rheumatic event as well as the immunosuppressive regime that you are using. So what can you use? Almost everything. Okay? We worry that at one hand, we are trying to tinker with the immune system by giving a checkpoint inhibitor, and yet you want to give immunosuppressant. But over the years, there's enough evidence and confidence that has developed that you can treat them. So for arthritis, arthritis, your usual stuff, NSAIDs, steroids, methotrexate, Plaquenil, anything, even your TNF inhibitors or tocilizumab. PMR, similar, Zika, similar, but it's just that it's pretty severe, so you might want to treat them more aggressively. It's the myositis that requires really serious treatment because it can be very serious and fatal. High-dose corticosteroids, consider pulsing, plasma exchange, your usual immunosuppression. Abatacept, reserve it, because abatacept, in a way, look at it, you're trying to work on CTLA-4, and you're giving a drug that works really exactly opposite to that. So you are nullifying the anti-tumor effect by giving abatacept. That decision has to be taken very seriously. So reserve it only for life-threatening diseases like myocarditis. Scleroderma, although it's a scleroderma, people think that high-dose prednisolone can be given. And vasculitis, also you treat like your usual vasculitis. A little bit about TNF inhibitors in this setting. So TNF inhibitors are a very pleiotropic cytokine. They have pro-inflammatory, anti-inflammatory, pro-tumor, anti-tumor effect, depending on which milieu, what is the the surrounding structure, what is the total overall inflammatory milieu, as well as acute versus chronic exposure. So this is an ongoing debate about TNF in the setting of IRAE, whether they are useful for the symptom resolution, but at that same time, do they then interfere with the immune therapy efficacy? And the jury is still out. There is some literature at this point, we think that the effect is neutral, and you can give it. In fact, there's some discussion and some literature coming up that TNFs may even potentiate the anti-tumor efficacy of immune checkpoint inhibitors. That's just very counterintuitive to me, but there's literature, there's some pathophysiology behind it that I will not go in detail. But it is now a recognized fact that TNF inhibitors can actually enhance the anti-tumor effect to the extent that people have started giving a combination therapy now. TNF inhibitors with anti-PD-1, which is basically an immune checkpoint inhibitor. Small study, phase 1b, show that there was no adverse event, no increase in adverse event if you combine a TNF inhibitor with immune checkpoint inhibitor therapy. There's an ongoing large multi-center trial, which is basically combining your ICI with canakinumab. So watch this space. But yes, this is really mind-boggling for me as well. There are additional considerations that you should take into account when you are faced with a patient with rheumatic IRAEs. One is, of course, how severe it is. What is the future oncology plan? What is the prognostication? If this patient has 3 months prognosis, forget the treatment. Just treat the symptom. You want the patient to be comfortable. But if this immune checkpoint inhibitor therapy is being given as a curative intent, then you will try your best to keep it going while managing the other features. If the patient is in a clinical trial, there might be limitations. Are there other organs that are affected? Because TNF inhibitors may help with your colitis as well, so don't play with methotrexate, just go to TNF if GI and arthritis both are present. And whether there are non-immunosuppressive options available like Silogox or topical therapy. And what is the life expectancy of the patient, as I just mentioned. Very interesting evolving era. Now people recognize that IRAEs or immune-related adverse events is not one entity. They are a heterogeneous group with very different pathophysiology depending on the tumor, the organ, and the treatment. And people are starting to now subcategorize them. Whether this is a lymphocyte-rich, whether this is mixed infiltrates, or which cytokines are playing a role. And based on that, they are potential targets. So if it's lymphocytic, these are your potential targets. And whether you can now do targeted therapies. So there's work going on. Don't blunderblast treat any IRAEs with methotrexate, leflunomide, or TNF. Look at which cytokine is playing the major role, and then you treat accordingly with the relevant but targeted biologic. Of course, you need full flow cytometry, biopsy, histochemical analysis. So this is research work, but very interesting that the field is evolving in this way. And you might see that IRA is being treated with differential therapies. What about immune checkpoint inhibitor therapy in patients who have pre-existing autoimmune disease? So we have patients with lupus who develop a cancer. Now your oncologist is going to ask them, can I give them? My answer is yes. Pre-existing autoimmune disease should not preclude the use of cancer immunotherapy because, again, coming back to the first principle, cancer is going to kill that patient. So you need to treat that cancer and you need to support your oncologist to continue this therapy. And there's a proposal from American Society of Oncology that you try and change your underlying rheumatic disease treatment from non-selective immunotherapy to selective immunotherapy, and then you combine it with your immune checkpoint inhibitor therapy. So these are new things that are happening. change it, and then continue in combination with your immunotherapy for your cancer. Do you then need to screen every patient who is going for cancer immunotherapy for an autoimmune disease? Answer is no, because not everyone gets it. And even if you screen, you're not going to deny that patient the treatment. So don't screen, but if they develop symptoms, then do the thorough evaluation. Or if they develop any paraneoplastic syndrome, then think about it. And then once it's developed, think what is the organ, what are the manifestations, what is the grading, what is the prognostication. After you have put everything together, then you treat, monitor, adjust. Lots of guidances have come up. If you're interested or you're faced with a patient, I strongly recommend reading this review published last year. I will not go into the details of it, but basically it says that you can use it. What if you are using in a metastatic situation, pre-existing autoimmune disease, you can combine things. You can combine an immunosuppressant and an immune checkpoint inhibitor. It is now well-known phenomena that patients who develop immune-related adverse event, IRAs, while on ICI therapy actually have better survival. Just makes sense, right? If your body is responding, then your T cells are going to kill the cancer. By the same time, you're going to get some autoimmunity. But those who do not respond to the first line, they have a shorter lifespan, which means if you respond to the first line, you're the best, right? But be aware, when you're looking at these studies, there's an immortality bias. Patients who do well are the ones who are alive. We're not talking about normal population here. We are talking about cancer patients. So those who are showing immune-mediated phenomena are the ones who survived. So maybe the ones who died did not have time to show you. So take these studies with a pinch of salt that IRAs predict better cancer response. May not be. There might be a mortality bias here. My take-home message would be, and a lot of slides, I must admit, are from a recent talk in ULAR on this topic, which I found very, very useful. Mechanism of action of IRAs actually help us to understand the pathogenesis of our usual autoimmune diseases as well. Arthritis and PMR are most common, but any autoimmune disease can occur, although they are atypical features. A previous autoimmune disease is not a contraindication to ICI, even if your flare may occur because you're dealing with a life-threatening disease versus an inconvenience. There is efficacy of cancer immunotherapy. It can be better in patients who have developed IRAs. I mean, that's possibly whether we are creating autoimmunity to cure cancer. Our job is to help our oncologists. But if you need more than 10 milligrams steroids, think of conventional DMARDs or biologics. And the last but not the least is this long-term challenge, whether we can combine the ND cytokines to enhance the cancer response to the immune checkpoint inhibitor therapy. Thank you very much.
Thank you, Dr. Lateef, for your deeply informative talks on both occasions.